All right, appendicitis. So we're continuing on in chapter 46 with lower GI. So appendicitis is basically the opening to the appendix becomes obstructed or inflamed, and the appendix is not able to drain any of the secretions which start accumulating. The appendix enlarges, it distends, and the swelling compresses a lot of those blood vessels. Damaged cells become infected, and that can become gangrenous, ruptured, and start spilling bacteria into the peritoneal cavity, which is called peritonitis, which we will study about next. Okay, so signs and symptoms. This is something that you're probably going to want to know. Might be a good select all the apply questions, something like that on the test. So signs and symptoms, diagnostics. So typically, the first one is going to be pain in that right-left quadrant, okay? And it's called McBurney's point, so positive McBurney's point. Another one is that the pain worsens when manual pressure to this point is released, and we call that rebound tenderness. Positive Rossing's sign is going to suggest acute appendicitis, and basically what this is that you're doing a deep palpation to the left lower quadrant, but the pain is going to be felt in the right lower quadrant. So even though you're pressing really hard on the left, it's going to be felt over on the right. Fever, nausea, vomiting, and white blood cells will increase. You'll have a very high neutrophil count with appendicitis. The treatment is going to be antibiotics. We have to treat that infection. We're going to keep them NPO until a decision is reached about surgery. We don't want them eating and drinking in case they do end up having to go to surgery. IV fluids given to prevent any kind of dehydration because we are keeping them NPO. And they probably haven't been eating since they haven't been feeling very good either. We don't want to give them an enema because this could cause perforation. You think about that appendix already being inflamed, being tight, giving them an enema might just be the thing that makes that kind of explode open or perforate. We're going to hold analgesics initially, and this seems kind of mean because they are in a lot of pain, but we have to avoid masking any symptoms. If the symptoms worsen, the surgeon will perform an appendectomy, okay? Another reason we want to hold those pain medications is if they're in very, very, very severe pain and then all of a sudden it lets up, that's a bad sign. That means that that appendix has perforated. And if it's perforated, all of that infection has now gone into the peritoneal cavity. And then that can cause really bad problems for our patients. So appendectomy, it can be laparoscopic, it can be a surgical incision, and so you can see both ways that they're able to do it, 1, 2, 3, or just a nice little incision right there. Recovery time is all individual based, but usually it's fairly quickly. Avoid any kind of strenuous activities, lifting. They may need an NG tube, especially if you have a paralytic ileus. And paralytic ileus is basically that gut is just not moving. It doesn't have peristalsis. It's not able to get the gas and the poop on out. One thing with after an appendectomy, we want them up, we want them walking, we want them to get that gas moving, and we tell them that it's okay to tube. In fact, you need to tube. Got to get that gas on out of there. Peritonitis is inflammation of that lining of the abdomen cavity, and it may be caused by, like we just said, appendectomy, perforation of a peptic ulcer, abdominal trauma, maybe a stab or a gunshot wound, ruptured ectopic pregnancy, and there are a couple of other things that can cause infection in that lining. Basically, the contents from other organs are going to spill into the cavity and make it become infected. The infection then grows on to inflammation, or localized abscess can even develop in that as well. Initially, the intestines respond with hypermobility, okay? So the peristalsis is really working overtime, but eventually it's going to lead to the paralytic ileus. Paralyzed, paralytic, it's just not moving. Air becomes trapped in the bowel, leakage of fluids, can go into hypovolemic shock. So hypovolemic shock, we have a lowered blood pressure accompanied with infection, okay? And if it's not treated, this will lead to sepsis, and sepsis can lead to death. So this can be very serious, and it can get out of hand very, very quickly. Here's just some pictures, you can see the stump of the appendix with sutures becomes very inflamed. It spills into the peritoneal cavity, causing infection all around. Distended small bowel, same way. You see that it's tight, it's very distended. Okay. Recurrence of abscess, acute peritonitis, necrosis of intestinal fat, hemorrhages all within the bowel, and can cause widespread adhesions. Okay, with peritonitis, signs and symptoms that we're going to see. Obviously, right here, very severe back pain and distension, very hard board-like abdomen, nausea, vomiting, absent bowel sounds. Diagnostics, we're going to be looking at their white blood cell count, and again, we expect that their neutrophil count will be elevated. We'll do an abdominal x-ray, and then we'll also just go off these signs and symptoms. If they're having all these textbook signs and symptoms right here, we also believe that it's going to be peritonitis. Okay, treatment is to identify and treat the cause. So if it was a gunshot wound, we're going to identify that, treat that cause. If it's an ruptured appendix, we're going to go in, we're going to take that appendix out. So we have to figure out what is causing the peritonitis. We'll probably insert an NG tube, and this is for decompression, removing that excess secretions. Remember, if they have paralytic ileus, it's not moving. The bowel is not moving on its own. So we're going to use an NG to decompress, suck out those contents, and kind of get that patient feeling better. IV fluid to prevent becoming hypovolemic, and remember we talked about hypovolemic, their blood pressure starts dropping. If it's accompanied with infection, it will lead to sepsis, and sepsis can lead to shock and death. We will do pain control. We don't want them in pain. Antiemetics to help control the nausea, vomiting, and then massive antibiotic therapy as well. Okay, so sometimes we can have obstructions, and it can be caused from some of these things we just talked about. It can be a mechanical obstruction or a functional abnormality, inhibiting normal flow of gastric intestinal contents. So you can have a partial, you can have a complete. Mechanical is going to be something more along the lines of fecal impaction, tumor, stenosis, different things like that. Functional is going to be that paralytic ileus. Again, it's not functioning correctly. It's not having peristalsis, and it's not moving the fluid and the gas out. Okay, and that will obstruct. All right, so complications, peritonitis, electrolyte imbalance, necrosis, and dehydration. And here we'll go into a little bit more detail on those 4 things. When the intestine is obstructed, the point above the obstruction is distended. Okay, so think about your tubing. You have the obstruction right here. Everything above it is going to be distended. It's not able to pass through. Gas builds up. It just becomes more distended. Peristalsis attempts to clear the obstruction, so your gut is trying to move it through, but this can lead to rupture. It becomes so tight that eventually it just can't go anywhere. It can't do anything else. The tubing, your intestine, becomes so tight that it just ruptures. And of course, if we have a ruptured gut, that means that we have infection in the peritoneal cavity. Increased pressure causes electrolytes to leave the intestine. Okay, so because of all this, because of that obstruction, your body is trying very hard to clear it. However, that causes pressure. That pressure also causes those electrolytes to leave the intestine, enter into the peritoneal cavity instead of being reabsorbed, which is the whole function of the intestines, reabsorbing those nutrients, reabsorbing those electrolytes. The pressure and the edema can impair circulation, which can cause necrosis. Of course, with necrosis, we know that that is cell death. Death means that necrosis means it can turn gangrene, and eventually they might have to lose that part of the bowel. Bowel obstructions impair absorption of fluids and nutrients. Okay, so what are some of the signs and symptoms with an intestinal obstruction? First, you're going to have a lot of pain, very severe abdomen pain, distension. You might have projectile vomiting, and with that, if the obstruction is high up in the GI tract, you're also going to see emesis coming up as well. So if it's higher in the tract, you're probably going to be vomiting. If it's lower, it might take a couple of days. You might not vomit at all, or it might take a little bit longer. Typically with obstructions, you're going to see them more in the small intestines than you will in the large intestines. So you will have some nausea. Probably have absence of bowel sounds, and this is all due to which kind of obstruction is it? Functional obstruction? Yes, you'll have absent bowel sounds. Remember, peristalsis, functional. It's not, it would be like the paralytic ileus. Increased high-pitched bowel sounds equals mechanical obstruction, usually heard above the obstruction. Okay. Cramping, wave-like pain, colicky, large bowel obstruction, constipation may be the only symptoms for days. So with a large bowel obstruction, like I said, they're less common than the small ones. The first sign might be constipation. So diagnostics, we're going to do an abdominal x-ray. It's going to show air and fluid collection, a barium enema as well. Treatment, NPO until it's resolved, IV fluids, electrolytes if indicated. Of course, if they're not taking anything by mouth, we still have to worry about their fluids and make sure they're not getting dehydrated. Antibiotics when infection is present. We could possibly use TPNs and lipids. NG tube for decompression, trying to get that bowel moving. Again, trying to get those contents, that gas out so it doesn't actually perforate. And then removing the mechanical obstruction. We can use laxatives or surgery. Of course, with laxatives, we want to be very careful because the prep is so hard on the bowel. We try not to use it too much because it could perforate. Okay, so diverticulitis is diverticulum, an outpouching of the mucosis of the GI tract. Okay, so usually it's just kind of weakening in the wall, usually going to be in the colon, especially the sigmoid. Adults greater than 50 years old is typically who it affects first, or affects. Diverticulitis is multiple diverticulum, and it's present without inflammation. Diverticulitis is the inflammation of the diverticulum. So you can see little pouches. Those are the diverticulitis. Okay. So food and fecal matter is retained in one or more of these pouches. They become inflamed, infected with intestinal bacteria. Most common is going to be the sigmoid area, and it's usually the cause is going to be because of a low dietary fiber. So you think they're just not eating enough fiber, it's not going through the system, their system isn't moving things out the way it should. Kind of sludge, it just stays there. And because it stays there, it can very easily start growing bacteria and cause an infection. Signs and symptoms, constipation alternating with diarrhea. So we're going to kind of watch our diet on this one. When we're not having any symptoms, we're going to try and bulk up and give them a high diet full of fiber. Whenever they're having symptoms and it's kind of inflamed, we're going to back off of that and pull back on the fiber. Give them more of a low residue diet. Okay, they'll have a lot of abdomen cramps, low left lower quadrant tenderness, fever, possible rectal bleeding because those diverticulums can start bleeding. And because of that, it can look like currant jelly stools, a maroon color. So that if they start bleeding, which they very easily can, we'll see either rectal bleeding or we'll have these currant jelly stools. Sorry, let's go back real quick. Diagnostic CT is going to be the first choice. Instead of doing aggressive bowel prep for these lower GI series, we can just do a CT and see it real clearly. You can do a barium enema on the lower GI series. Of course, you're going to be running a risk for perforation. It's just a little bit harsher. The CT, they can take a scan and it doesn't run the risk of perforation or anything like that. They will have high CBCs, high white blood cell counts, because of the infection as well. Treatment, okay, so like I said, if it's inflamed, we're going to do a temporary low residual diet when symptoms occur. And so basically that just means cut out the fruits, the fiber, the nuts, the whole grains, things like that that have high fiber. We're going to bulk up diet with bran and Metamucil to avoid any kind of constipation whenever they're not having the inflammation, whenever they're not in kind of that crisis thing. If severe symptoms, we'll do NPO with IV fluids, antibiotics when they need to be on antibiotics, avoiding any kind of Lasix, enemas unless ordered by the doctor, because again, we don't want to run the risk of just doing too harsh of a bowel prep for them. Treat the pain with meds, surgery if complications occur. So surgery is reserved for if they have an obstruction, perforation, severe bleeding, anything like that. And if that does happen, the affected portion of the colon is removed and they may need a colonoscopy, colostomy for like a colostomy bag temporarily, but it might be something that they can go in later and reverse and go ahead and reconnect the bowel and allow them to have normal bowel function. Nursing, okay, assessment, encouraging that high fiber diet when they're not having bad symptoms, avoiding constipation, not suppressing the urge to defecate, encouraging PO fluids, drinking anywhere from 6 to 8 glasses, large glasses of water every day, encouraging exercise if lifestyle was sedentary, notifying the doctor if there's any blood in stool, any of those current jelly stools, anything like that, pre-op, post-op care if surgery is needed, and then pain management. So with some of the lower GI disorders, we also have absorption disorders, which occurs when the GI is just unable to absorb one or more of those major nutrients, carbs, fats, or proteins. You can have the diverticula, the IBD, celiac disease. Those are just to name a few. With celiac disease, you probably know someone in your family, maybe some friends who actually suffer from celiacs. And this is just a sensitivity to the gluten. And gluten is found in wheat, barley, oats, rye. It's not found in corn, so they can still have corn products, but anything dealing with wheat, barley, oats, and rye, it just upsets their stomach. Gluten's kind of used as a filler, a thickener, a binder in many products. Even those that are labeled wheat-free, you still have to read the nutritional facts and make sure that you are actually eating something that is gluten-free. When it's ingested, it damages the intestine and continues even in the absence of symptoms. Okay, so celiac disease, signs and symptoms: malnutrition, weight loss, weakness, fatigue, malaise, frequent loose, bulky, foul-smelling, gray-colored stools with increased fat content, diarrhea. The treatment is just simply to avoid and eliminate all products containing any gluten. What we also have to teach our patients is that even when symptoms go away, it doesn't mean that you can slowly incorporate gluten back into your diet. You're always going to have this problem and you don't want to eat gluten because of it. We do want to encourage a high calorie, high protein diet because of the malnutrition and that weight loss to kind of get them back on track. We're going to stop here and we will pick this up next go round.